Hi, my name is Arlene D'Souza. I'm a Hematology and Medical Oncology physician for Northwestern Medicine Regional Group. Today I'm live from Northwestern Medicine Del Mar Cancer Center to talk about melanoma. If you have questions, please post them in the comments section and I'll answer them at the end of my talk. Melanoma is a form of skin cancer. In the United States, it's the 5th most common cause of cancer in men and women, with more than 90,000 Americans diagnosed each year. It begins in melanocytes, which are cells in the outer layer of skin called the epidermis, which make melanin. Melanin is the pigment that gives our skin color. When these melanocytes change into abnormal cells and grow out of control, people develop melanoma. The exact cause of melanoma may not be known, but there are several risk factors that increase the risk of developing disease. The primary risk factor is exposure to ultraviolet radiation, including sunlight and tanning beds. Risk increases with higher amounts of exposure. So early exposure, particularly for people who had frequent sunburns as a child or a history of one or more severe blistering sunburns, can increase melanoma risk. Fair skin is a risk factor. So people with fair skin have less melanin, which causes less protection from damaging ultraviolet radiation. Other factors for people with fair skin include red or blonde hair, people with light-colored eyes, people who freckle or sunburn easily, and people who burn easily. Those patients are at increased risk for sunburn. People with many moles are at higher risk as well for melanoma, and this is considered people with more than 50 ordinary moles or people with unusual moles, which are known as dysplastic nevi. Family history is also an important risk factor. People with a close relative, such as a parent, sibling, or child with melanoma, can have an increased risk of developing melanoma. About 10% of melanomas are familial, which is defined as 2 or more blood relatives with melanoma. People with weakened immune systems are also at increased risk. So this might include people who have had organ transplants, cancer patients on chemotherapy, and people who have autoimmune disease on immunosuppressive therapies, or people with AIDS. Melanoma can develop anywhere on the skin, but they're more likely to start on the chest or back in men and on the legs in women. Other common sites of melanoma include the head and face, and also the eyes, mouth, digestive tract, genital, palms of the hands, soles of the feet, and under the nails. So when you're trying to decide if you have a suspicious mole or if it's something you should worry about, it's helpful to remember the mnemonic A, B, C, D, E. So A stands for asymmetry. Ask yourself, does one half of the mole look different from the other half of the mole? B stands for border. So are the edges jagged or uneven? C stands for color. So are different areas of the mole pigmented in different ways? D stands for diameter. Is it greater than 6 millimeters? Or another way to think about it is the mole larger than the eraser on the end of a pencil? And evolution. So has it changed its size, color, or shape over time? Skin affected by melanoma can bleed, become swollen, red, or crusty. Sometimes people refer to an ugly duckling sign. So what that means is, does the melanoma look different than the other moles that you have? And it's normal to have moles and birthmarks on your skin, and not all of them are melanoma. But if you think that you have one that might be abnormal, you should have a low threshold to discuss it with a doctor. So the way doctors diagnose melanoma is by a skin exam, and it includes the parts of the body exposed by sun and also not exposed by sun. Dermatologists sometimes use a tool called a dermatoscope to better visualize abnormalities in the skin. If they feel like a lesion is suspicious, then they perform a biopsy by removing either the entire abnormal area or a small sample from the abnormal area, known as a punch biopsy. This biopsy is then examined under a microscope to determine if it's melanoma. After you have a diagnosis of melanoma, the next step is determining the stage. And what this means is what is the extent of disease that you have. So the first thing that we do is we determine the thickness. Generally, the thicker the melanoma, the more serious the disease. And subsequent treatment decisions are based on the thickness. So for patients with a thin melanoma, which we consider less than 0.8 millimeters in thickness, surgery to completely remove the melanoma and some normal tissue around it may be the only treatment necessary. When melanomas are greater than 0.8 millimeters, we typically evaluate it further to see if it has spread. So the most common site of spread are the lymph nodes draining the area of skin where the melanoma was detected. So to determine if a melanoma has spread to the lymph nodes, a sentinel lymph node biopsy is recommended. So a sentinel lymph node biopsy is done by a surgeon, and essentially the surgeon injects dye into the area where the melanoma was removed. The dye flows into nearby lymph nodes, and the first lymph node to take up the dye is removed. If the lymph node is cancer-free, there's a good chance that the melanoma has not spread beyond the area it was discovered. If the lymph node does show melanoma, then additional treatment after surgery is recommended. For people who have melanomas greater than 0.8 millimeters thick, a sentinel lymph node biopsy is typically recommended. And when people are kind of intermediate and wondering if they would benefit from a sentinel lymph node biopsy, we often look at microscopic features of the melanoma. So what this means is we look at things like ulceration, which is there breakdown in the skin on top of the melanoma? We look at the mitotic rate, which checks the number of mitoses, which is a characteristic of dividing cells. And in general, a higher number is considered associated with higher risk disease. And then a discussion can be had regarding the benefit of doing a sentinel lymph node biopsy, kind of when all of these factors are considered. If a sentinel lymph node biopsy is positive, we typically recommend adjuvant therapy. And this means treatment after the cancer has been removed. The goal of treatment is to stop the growth of any remaining cancer cells that were not removed during surgery and to decrease your risk of recurrence. Immunotherapy is typically used as adjuvant therapy. Immunotherapy with checkpoint inhibitors are agents that enhance the body's immune reaction against melanoma. We usually give this intravenously. It's done at the cancer center, and it's typically given for 1 year. For people whose melanoma has spread to other parts of the body, we consider them to have advanced or metastatic disease. And in many of these cases, the metastatic melanoma can't be cured. The goal of treatment, then, is to shrink the disease and stop the growth of the melanoma and prevent its spread to other areas. In certain situations, when there's a few areas of melanoma without cutaneous involvement, surgery or radiation therapy can be considered. Immunotherapy is also with checkpoint inhibitors that stimulate the body to react against melanoma, like nivolumab, pembrolizumab, and ipilimumab are also types of treatments that we typically use in the setting of metastatic melanoma. We sometimes use targeted therapy, so about half of metastatic melanomas contain a mutation in a gene called BRAF, and this drives the growth of cancer cells. So there are several drugs that block this protein or the pathway it stimulates and causes the tumor to shrink. So BRAF inhibitors are vemurafenib, dabrafenib, and encorafenib. These drugs are given in combination with MEK inhibitors, trametinib, binimetinib, and cobimetinib, and giving both agents together has shown to be more effective with limited toxicities. Sometimes you can use traditional chemotherapy, but it has been less effective than the other methods that were described. Sometimes for patients with BRAF mutations, we can use combinations of targeted therapy and checkpoint inhibitors. And in certain situations, we could use something called TVAC, which is an oncolytic virus, which can be injected into a lesion. In scenarios where we would consider using this are in people with cutaneous, subcutaneous, and nodal metastases with limited visceral involvement. And in these people, intralesional therapy might be helpful. To just briefly talk about investigational therapies, there's a monoclonal antibody called Retilimab, and what it's thought to do is restore effector function of exhausted T cells. So this has been given with nivolumab, which is one of our classic checkpoint inhibitors, with some limited success, so it's being investigated in current randomized trials. Other investigational studies that are being done are granulocyte macrophage colony stimulating factors, which essentially is a protein normally made by our white blood cells that stimulate our immune system. So this is given with immunotherapy and being studied to see if it's effective. Fecal microbiome transplantation is also in early phase clinical trials. So the thought is fecal microbiome transplant can overcome disease resistance and promote treatment response in people who have progressed on immunotherapy. Combinations of TVEC and immunotherapy, as well as IL-2 agonists with immunotherapy, are also being investigated. But aside from treatment, I think the most important thing to discuss is prevention of melanoma. Melanoma is the most common form of cancer affecting young adults between the ages of 25 and 29. So if you think that you are high risk for melanoma, or if you have high risk features, it's important to discuss with your healthcare provider the benefit of regular skin exams. We discussed that UV radiation is a major risk factor for melanoma. So interventions that decrease UV exposure are important to consider. So something obvious like shade, so rather than being in direct sunlight, trying to be in shade when you're outside during peak sunlight hours is important. Avoiding or limiting sun during its peak hours, which is 10 a.m. to 4 p.m. Broad spectrum sunscreen, which means it protects against UVA and UVB, with an SPF of at least 15 on a daily basis is recommended. But due to inconsistent application, the American Academy of Dermatology actually recommends broad spectrum sunscreen with an SPF of 30 to 50 when you're outdoors. You're supposed to apply sunscreen 20 minutes before being in the sun. And the two main kind of sunscreens are mineral sunscreens, which physically block and scatter rays. These are typically titanium dioxide and zinc oxide, and chemical sunscreens, which absorb UV rays before they damage skin. These are avobenzone and octisalate. The best sunscreen is really the one that you're most likely to use, and they both have different consistencies. So the mineral sunscreens tend to be chalkier and blend less into the skin, but essentially whichever sunscreen is more palatable is the one that dermatologists would recommend. And in terms of how much sunscreen to apply, in general, there's a teaspoon rule. So 1 teaspoon on the face and neck and 1 teaspoon on each upper extremity is considered adequate, and 2 teaspoons on each lower extremity, as well as on the chest and back. People should remember to reapply every 2 to 3 hours, or if sunscreen has been wiped off. So this includes profuse sweating and if you've toweled off after being in the water. And wearing tightly woven fabrics in dark color can also protect from the sun. This is all I have for now. Are there any questions?
We've got some.
Okay.
Yes. Dr. D'Souza, question that came in: why is melanoma different from other skin cancers?
So melanoma is actually much less common than other forms of skin cancer, which are squamous cell carcinoma and basal cell carcinoma most commonly. These are the 2 cell types located in the upper layer of the cell, or the epidermis. Melanoma is more dangerous because it's more likely to spread to other parts of the body if not caught and treated early. And in contrast to melanoma, basal cell and squamous cell carcinomas grow slowly and rarely spread to other parts of the body, so resection alone is enough to treat them, typically.
Another question: who should be checked for melanoma?
There's no standard recommendation for population-based screening, but higher risk people, so people with a positive family history, people with multiple moles or atypical moles, are recommended to be screened at least once a year.
Let's see, another question. If I have melanoma, am I at increased risk for other cancers?
Well, we said that there's a 10% familial risk of melanoma in certain scenarios. So if melanoma is caused by certain genetic mutations, there may be a risk of having other cancers. So families who have the CDKN2A mutations can have increased risk of pancreatic cancer. So you might want to see a gastroenterologist and discuss surveillance. Our families with a BPA1 gene mutation are observed to have cutaneous and ocular melanoma, in addition to renal cell carcinomas and mesotheliomas. Some studies, but not all, say that BRCA1 and BRCA2 mutations, which are associated with increased risk of breast, ovarian, and prostate cancers, have seen a trend towards increased melanoma, although this has not been observed in all studies. So it is important, you have melanoma to consider kind of what your family history is and if you should investigate your risk for other cancers.
So if I have a family member with melanoma, should I see a genetic counselor?
Well, if you have 2 family members with melanoma, that would certainly be high risk, and I would recommend seeing a genetic counselor. And also, if if you have family members who have atypical nevi and you have it as well, it's always appropriate to discuss it with your healthcare provider, whether or not there would be a benefit in seeing a genetic counselor.
Another question for you that's come in. If I am on immunotherapy, am I more susceptible to COVID?
So as you know, COVID is rapidly changing, but as of this moment, there have been some studies which have shown that immune checkpoint inhibitors do not result in a higher risk of severity and hospitalizations in people with COVID. So the risk or concern for COVID would not be a reason to hold off on immunotherapy or not do it.
This kind of touches on something you talked about. Questions come in. How soon after Sentinel lymph node biopsy would I start adjuvant immunotherapy?
So typically you start it after you've healed from surgery. So that could be as soon as 2 to 4 weeks after.
Looks like one more question for you, and that is, what are the common side effects of immunotherapy?
So immunotherapy activates our immune system. So side effects that are associated with it are essentially your immune system attacking your own body. So it could be rashes, sometimes people get diarrhea, sometimes people get thyroid abnormalities or hormone abnormalities. You can get pulmonary toxicity associated with immunotherapy. Now, there's a long list of potential toxicities, but very frequently, it's very well tolerated for most patients.
Okay, one more question
Sure.
actually. That's come in. After the surgical removal of a melanoma, is a skin graft typically necessary? Do you have to get a skin graft?
Not necessarily. So essentially, whether or not you need a skin graft is based on whether or not the surgeon thinks that they can close the wound. And so if it's been a large lesion or a lesion in a difficult location, often on the head or ears or face, then often skin grafts are seen more commonly.
That is it with all questions, yes.
Well, thank you. Thank you for joining us.